Okay, so a couple things updating with intubating. We have an intubation drape that I'll show you how to use and deploy later, but also a little bit of an adjustment to the intubation kits. The contents of the kits actually aren't going to change significantly, but just a thing regarding the nasal cannula. So before we had a nasal cannula underneath the BiPAP mask, that actually was necessary in order to provide CPAP. I won't get into the mechanics of it in the video because it takes a little while to explain, but that was necessary to actually give the patient CPAP in this setup. The issue was that it could cause a little bit of a mask leak, had the potential for that. So we came up with another way to get flow to the patient past the inspiratory valve on the BVM that can kind of obviate the need for the nasal cannula. So what you're going to do, first thing I'll point out actually is that our non-vented BiPAP masks, which are the correct ones to be using, are in short supply. So this is actually a vented BiPAP mask. This is not what you're going to be using, but it's less valuable than our non-vented ones. So again, make sure you're using non-vented BiPAP masks in real life. So you have your mask hooked up to the viral filter here. These viral filters have a little port right here. If you want to come in here, Mara, have a little port right here that's beyond the filter. So anything that comes through that is going to be filtered air. One thing that will hook up to that is if you take your standard suction tubing, which we should have in all the rooms to begin with, so this doesn't need to be added to the kits, but if you take your standard suction tubing and you hook it up to your oxygen supply on one end, and on the other end, you take some shears, cut that end off, that will fit over this little port right here, okay? So you can supply post-valve oxygen to the patient that's going to help pressurize that PEEP valve this way. What I would do, we were doing the nasal cannula at 6 liters before because it's underneath the mask and past the viral filter. If you're doing it this way, I would probably turn the oxygen up to even 10 or 15 or so because there's a little bit of increased resistance through that filter. But you will get flow through that filter to the patient. So turn it up to 10, I think 10, 15, somewhere in that range before you put it on the patient. So when you come in the room, you're going to set that up first, as we discussed before. I'm going to put this mask on the patient. I'm not going to have the oxygen flowing just for the demonstration purposes. But again, you've got oxygen flowing through that repurposed suction tubing at about 10 to 15 liters per minute. So at that point, if you have a good seal, you should be relatively protected. Again, you're wearing good PPE, N95, face shield, all that stuff at this point, but this should give you that added layer of protection. Again, you probably should be assembling the rest of the stuff outside the room before you go in, but as we discussed in the previous video, you got your BVM and your PEEP valve attached to it there. So you can come in, attach this down here. Make sure that you get a good connection between all these. You don't want any of these popping off, so make sure they're nice and secure. And then you're going to hook this up to your other oxygen source. And this one, like we discussed before, should be at flush rate, which means go up to 15, but then keep turning it until you can't hear the oxygen increasing any further. So again, I'm not going to turn that one on, but that should be at flush rate. So she's on the pre-oxygenation setup. You're going to keep the patient on this for 10 minutes or so, 5-10 minutes before you end up intubating them. A little bit more information has come out that suggests that non-rebreathers aren't quite as bad as we might have initially thought in terms of aerosolizing stuff. This is still definitely going to be safer, but if you have a crashing patient or this is just like way too complicated to set up, it's not the end of the world if you just use a non-rebreather. There is a difference, but it's not enormous, especially if you have good PPE. The one thing that this is much better than a non-rebreather in doing is getting more oxygen into the patient, not necessarily because the flow rates are higher, but because you have PEEP going into the patient. So you're going to recruit alveoli much better before you end up intubating the patient. I have seen a couple of cases so far in our department where patients have been pre-oxygenated with a non-rebreather, and they get their sats up to 100% before they tube, but then they administer the succinylmalate, and within 45 seconds, the patient's sats are in the 70s. So this is going to give you better pre-oxygenation than a non-rebreather and give you longer safe apnea times. So I would definitely recommend having everything from your kit laid out on a table, like maybe outside the room before you come in. So you have everything laid out here. You got the patient on your pre-ox setup. You're going to I think about a minute or so before you're ready to push drugs, take your end-tidal CO2 detector, your color change device, and again, maintaining the mask on and the viral filter on, pop the BVM off, put the end-tidal CO2 on here, and then pop that mask back on, or the BVM back on. I would do that, like I said, about a minute or so before you're going to push drugs, rather than when you're first setting this stuff up, because this might add just a little bit more resistance to the circuit. But at the same time, I don't want you doing it as you're RSIing the patient, because then that's just too many moving pieces when kind of a very simple set of steps is a little bit more critical. So do that like a minute or so before you push drugs. Give her a little bit more time to pre-oxygenate, and then we're ready to go. So this is the one addition to the kit. This is the intubation drape here. Labor Pool made a bunch of these for us. There was another video that was circulating, not quite as widely because I didn't have everything finalized, that had a little bit less opaque of material. Unfortunately, we weren't able to source that quite as easily, so this stuff is from Home Depot. It's a little more opaque than I would like, but you're doing video laryngoscopy on these people, so it shouldn't matter that much. Our video is separate from the blade. Will, can you just help me bring this out? So probably helps to get this out with two people. One other thing that I'll say is that the ports that are on here, the Labor Pool cut with like an X-Acto knife. In some cases, I've looked through a bunch of them that they made. They could be a little bit longer, or they're not quite totally cut through. Just inspect it before you get ready to do what you need to do with the RSI, and just make sure that these openings are going to be big enough for you. These are hand ports here, so your hands are going to go through there, and then this is a chest port down here in case somebody needs to provide cricoid pressure or do anything else around the chest, put monitor leads on or whatever. And we'll start off with it over the patient's chest while they're still awake, just to be in position to be ready to pull over their head once we give drugs. So again, just try to, if you got bigger arms or you're in a bunny suit or something and you need to open these up a little bit more, don't be afraid to open them up just a little bit more. The duct tape really just serves the purpose to show you where the ports are so they can be easily identified. So you have this ready, we're gonna have it over the patient's chest when we're ready to give drugs. All right, so we're gonna get ready to push drugs. Just a word of warning to the patient, just make sure that they're aware of what's gonna happen. It's obviously a little bit scary to be in this situation to begin with, especially if you're getting a sheet pulled over your head. It's probably be a little bit less scary if you just let them know beforehand so that they're prepared. Make sure that you have all your stuff where it needs to be. The position I would put it in is underneath your towel roll. Your towel roll is there to position the patient's head forward. Get it well secured underneath the towel roll so that you can reach in and grab it when you have the patient apneic and ready to go. So we're gonna, Will is gonna push drugs. Will's our pushing drugs nurse. So he gives the sucks, etomidate, whatever. And right around that time, I would say very shortly, at the time that they're giving the paralytic, I would go ahead and take off this mask here.
So if you're worried about the patient desaturating quickly after you take the mask off, you could probably give it up to, but no longer than 20 to 30 seconds after you give the paralytics to take the mask off. The issue is that if you wait too long, it's going to give you a limited amount of time to get your equipment situated underneath the drape once you pull it over the patient's head.
So I'm just going to unclip here. And what your respiratory therapist should do is take that mask off, and then again, you won't need this this source of oxygen anymore. So you're going to take that off as well, and then pop that cap back onto that viral filter piece there. Just to show that from a little bit of a different angle, when the RT is taking that mask off the patient, they're going to take the mask off here. They're going to take that oxygen source off, and then cap there. So now this BVM is ready to be hooked up to the endotracheal tube once you actually have it in the patient. If you need to bag the patient because you have a hard time getting the tube, I would just make sure that mask is available on standby, because you can throw it back on there and then put it on the patient and then use this as a BVM if you need to, if you fail at your first pass. At the same time, while the RT is doing all that stuff, the nurse and I are going to pull the sheeting over the patient's head. You're going to need those hand ports to be a little bit above the patient's head. And again, as the patient is falling asleep, make sure you have your hands in there pretty good. You're going to need to probably get in, to forearm depth or so. It helps if the nurse can kind of tent it a little bit so you have a little bit more room to work. Get your hands in there, get your blade ready, get everything really set and ready so that when the patient actually becomes apneic that you're ready to go. So I'm going to pull my tube out here and go ahead and intubate. Oops, sorry. I'm going to go ahead and intubate the patient. So I've got the patient intubated here. As usual, pull the stylet out. You or the respiratory therapist can put the cuff up, and then we're going to hook that BVM setup up to here. Okay. This little strip, the RTs already know this, but this little strip needs to come out, needs to get pulled out so that the color will actually change. And then you bag your patient and you're all set. One thing in terms of getting this off, these are disposable, so you can just rip this or cut it to the end and then just take it off the patient that way.
So not all, but at least some of our endotracheal tubes have these black lines on them. The black line is designed so that when you see that black line going to the level of the vocal cords, that tells you that the tube is going to be in good position and that you don't need to auscultate. If you have a taller patient, bigger patient, you might need to use the top black line, but in most cases the bottom black line should be sufficient and you won't need to auscultate or touch the patient after.